So I would like this to be as interactive as possible. We have a 15-year story to tell you. I never usually have 2 hours. So I don't think you will be too bored. I've got a couple of videos in there that should kind of mix it up a little bit. But I would like to know a little bit about you all. So how many are actually working in primary care? No one? How about specialty care? Physicians? Administrators? Great. Researchers? Wonderful. Okay, welcome. And you're from all over? East Coast? Midwest? West? Did I miss anything? South? Oh, Australia. Hello. Awesome. Great. Welcome. Welcome. We have friends in Australia, too. Well, I bet you're glad you're not on the northeast coast right now. They're getting a terrible northeaster. That is really looking kind of scary. I want to share with you the journey of how we even got to call what I'm going to show you population health, which is the focus of where many of us are now with our health systems and our communities. But there's been a ways to get there over the time for Intermountain Healthcare. And we're also going to talk about team-based care and how we use the mental health integration program to really detail that out. And we're really talking about team-based care for all specialties, not just psychiatry. But I always like to start with, why do we do what we're doing? Yes, we want to reduce costs, we want to improve outcomes, but it's really all about the patients. And so I'd like to read you a little bit of a transcript of one of our ethnographic. I have a PhD in medical anthropology. I would like to read you Sarah's transcript and her perception of what her experience was being treated and cared for in one of these clinics that had reached this high level of team-based care performance. And as I tell her story, you can listen to it, and then I'm going to tell you why she was able to experience this over time. I believe my doctor was actually been the first doctor that ever really cared about me as a whole person, instead of just take these drugs and see you next year. I watched him help my husband first and saw that it made a difference. This is a family doc. And then I called to make an appointment for myself. My mom had depression, and people around her made her feel like she was less than whole for having to take medications, and that therapy was only for people who had schizophrenia. I've grown up with that it's my problem, it's just me being nuts. So having my doctor make it like a day-to-day thing, and that it's not my choice or brought on by something I didn't do, that's actually a physical thing. He said, if you had cancer, we wouldn't not treat your cancer because you're nuts. Because someone told you that, you really need to take care of yourself. And he made it more of a human thing and something that I can deal with. He made it easy for me to talk about things that I wouldn't talk to a doctor about. He's a good listener, open, and when I needed more than medications, he hooked me up with other good listeners that he worked with right here in his clinic, someone that he knows and talks to. I know I need to follow his advice. This is important now with all the focus on patient engagement. I know I need to follow his advice, and if I do, it's easier for the both of us. If I don't, it takes longer, and I don't get the expected outcomes. This is the patient's words. If I don't do it, I don't get the expected outcomes. He can always tell the difference. So when I try, it shows him that I care about what he says and that I'm taking my own recovery seriously. Again, the patient's own words. I guess I would say what matters most to me is that we matter. I know my doctor really cares about well-being, my well-being, and my family, so that I know that then when he recommends, it will be something that will benefit us, and that he knows what he's doing. So what I want to share with you now is, how could this possibly have happened in the healthcare situation we have now? And what is behind this doctor and patient's experience that makes it possible in this day and age for a patient to feel like their doctor's a good listener? So keep that in mind as we're moving forward. And I'd like to talk with you a little bit about what Raj introduced, the value of care delivery science, and how we've used mental health integration and team-based care to solve big, big problems. I'll also share with you kind of how we do it, and I have some of our team here that's actually living it every day. I'd also like to engage you all in having a discussion about the economic and cultural barriers to really building value for this in our systems of care. And we'll have an open discussion at the end about population health and how do we really redesign care to meet patients and families where they are. So huge problems, some that are facing your communities and facing us globally. Depression as a chronic disease is the leading disability worldwide. This is not just limited to the United States. Costing us incredible amount of money, especially with medical comorbidities and significant mortality rates, and the opioid crisis is only one of them. 1 death every 20 seconds in the world from suicide. Big, huge issues. If you just look at the opioid and substance use issues, this year alone, 2017, this past year, 46,000 people died of the opioid crisis. Is this a medical condition or is this a social illness? These are things for us to begin to start thinking about. Do we do a care process model for opioid use, or is substance use another chronic condition that we need to have in terms of really figuring out how we're going to help these families move forward? Lots of stats out there. Another trend across our country, how many of you work in a hospital? How many of you board psychiatric patients in your ER? Huge problem, and one that is still trying to be sorted through. Many systems are beginning to think about a team-based care approach and bringing screening and new ways to do it. But my favorite example of this trend was when I went and consulted South Shore Boston Hospital, and we went down to their ER. And their ER docs had run charts, and they were doing quality improvement, and they had gone through Brent James training that you're all doing here. And they showed the screens on the check-ins for the patients coming in. Heart attack, behavior problems, anxiety, overdose. And there was no way for them to discriminate what was a mental health issue, a social issue, or really a medical issue. And then we went to the MA's desk and all the little screens there, and they're monitoring patients. And there's a 17-year-old boy in a room, in an locked observation room. And I said to the MA, to the nurse, how long has he been there? 3 weeks. And my heart dropped. And I said, has anyone come to visit him? And she looked at her desk and went, nope, nope. Now, I had been prepared for this because this was an example of our failed system because there was no place to send this child. Those are examples of the huge problems and the impact it has on delivery as we don't put together and integrate it. Back again, the issue on access to firearms. Everyone in this country has access to firearms, but not access to mental health care and quality mental health care. A huge problem for us to consider. Huge problem, why it's been separate for so long, but now it's in our community. It's part of our population health issues. It's part of being able to understand how do these families live in ambulatory, they live in the community. They come to their primary care, they come to the ER. How are we going to address some of these issues? Mental health and health care is an incredible market now. There's an incredible market where people are trying to put together the best they can ways to improve health care. Integrated team-based care is one of them. But when you ask the people why they have not been delivering health care, health insurance wasn't the big issue, coverage. It was basically, generally, we couldn't handle the problem, we don't have the treatment, and we can't afford it. We can't afford to provide the treatment that we have covered. So these are huge, huge economic burdens to us in terms of the prevalence. So we are in the same boat as all of you. We've built a rescue healthcare system, and we're moving towards working on a healthcare system that's actually working on prevention and management of chronic diseases. But we try to keep this front and center because there are those forces of patients coming to the ER are really incredibly high and accompany tragic failures with them. You've seen a lot about Intermountain, so I'm not going to go through all the different structures of Intermountain, but what I wanted to focus on is our mission and why this mission is important for population health and how our mental health integration program fits into it. In the beginning, when I started in 2001, we are the leading healthcare system to do evidence-based science. Then it moved to Healing for Life became our tagline, which is still on there. Now our branding is helping people live the healthiest lives possible. We're finally moving out into the community and the population and taking a look at that. These are all the different offerings at Intermountain Healthcare, but a little bit of the history is that mental health integration started in our medical group. Has anyone talked with you? Has Todd talked with you about our medical group and how we're organized? Well, we have a medical group, a health plan, and then our hospitals. In the medical group started, I think, in 1994. And then in 1998, they began to have private primary care physicians join the medical group. Intermountain bought their practices, and they joined part of this big system, and Intermountain provided operational support for these doctors in the community. In one of those medical groups that had just joined in 1998, the physician said, absolutely, this is going to be great for us. Thank you for taking away some of the operational headaches, which actually never really go away. And we're really excited about working with Brent James and improving care for diabetes and asthma. But what are you going to do with all the substance use, domestic violence, depression, and anxiety that our families are coming in with? That's our biggest burden. And the CEO at that time, Dr. Linda Leckman, who just retired last year, listened to them. And our CEOs at that time, Charles Sorensen and that, listened to these physicians. They wanted to engage these physicians to become part of Intermountain, and they began to build the mental health integration program around them. During that time, Dr. James and I went back to Washington, D.C. and participated in the first Surgeon General's meeting on integrating primary care and mental health. And from that meeting, we established from the Surgeon General's report on mental health, 1999, the first report on mental health in this country, we chose this definition as part of our mission to build upon Intermountain's culture already of improving care. A state of successful performance of mental and physical functioning resulting in productive activities, fulfilling relationships with others, and the ability to change and cope with adversity, to adapt to that. Would you want that? Yeah, we all want that. So the most important part of this is we're not talking about mental illness. We are talking about mental health as a critical part of overall health. Sure, we have mental illness, we have medical illnesses. They're all illnesses. But this is a state of successful performance. This has been our definition moving forward. We had to train our primary care docs on what did mental health mean, because everybody has a different perception. Mental health was scary back then. Not as scary now, but still difficult. We had to define what is integration. What do we mean by mental health and integrate? How are we going to integrate this normalized definition? And what it really meant for us, and still means for us, is to take groups of people that are committed to doing mental health and providing mental health and feeling mental health and form and coordinate into a functioning, organized whole. We had to bring together psychiatry and primary care, which is no easy task. They are two very different species. I'm glad I got a couple of laughs out of you, right, Travis? Our psychiatrist. We have any other psychiatrists in the room? No, at least we have one. Okay. All right, and basically we said, we don't care which one you are, we're going to have fun. And we're doing this for patients, and we're doing it for families, so yes, specialists, you're special, and yes, primary care docs, you do all the work, but we're going to put you together and figure out how to provide team co-production, which is a concept we share with the UK, where you don't service patients, you co-produce the outcomes together. You see patients and families as bringing assets to the partnership and working on this together. The way we target functioning the group and to form as a whole is we have at Intermountain called a standard clinical line of thought. We have care process models that help us all get on the same page. And they're difficult to come up with, they're difficult to implement, but they are the way that we provide care in our delivery of science. And that's what we have done with mental health integration. So over the years, we have evolved to really this core foundation. And that is our focus being on what are the conditions for good health. And that this is really at the bottom of being able to help people live and work and live the healthiest lives and really reducing their risk of illness. So this is really what our focus is on today and will be for the near future. This is a slide shared from our friends in Sweden. And Sweden has a very interesting way to look at what I just shared about focusing on what are the conditions for good health. The way that they're beginning to reorganize their country and their population is these are really the majority of the population. This is like everyday life. People are just living their everyday life. Then here's another significant part of care in their population where they may need some support in the community. Yoga, exercise, community contacts. They don't come to primary care till here. Then another percent of the primary care needs here, and here's specialty care. So that's a very different way of thinking about the value and the cost. Where do we spend most of our time in healthcare? Which part of the triangle do you think? Here. Right there. And it costs too much, it costs too much, it costs too much. Keep figuring it out, keep figuring it out. When the majority of the population is out there. And we'll show you in the JAMA study why we got such great results, because we really kept a majority of the population out of here. We kept all those people out of having to go there. So it's an important way to just think about it. I wanted to share that with you. These are basically the 3 building blocks. You've learned this, hopefully, in the classes with Todd and everyone that's the experts here. But these are the 3 building blocks that helped us build mental health integration. Had this not been in place, I don't think we'd be where we are. Intermountain's ability to bring teams of providers and administrators and governing people together to have a common vision, clinical work process from the minute the patient walks in the clinic, out to the clinic, back to the community, and back again. That is detailed at every step. It's detailed with clinical information. It's detailed with data. And then to take that data and evaluation and have it be transparent and give it back. So those are the 3 core things that you'll see as we begin to talk. These are, again, Intermountain's way of improving the science and the delivery of it and that systematic approach. And then I love this thing that Brent James always said, and I thought it was really corny when I first got to Intermountain. I was like, yeah, right, what? You come around doing the right thing? And they really do. And it really works. So it's really fun to be able to see a huge institution like Intermountain really having a conversation every day. Are we doing the right thing? And we're having that conversation now because we're reorganizing. And everyone in this company has been asked to say, what do you do that provides value? Is it the right thing for patients and families? And if it's not providing value and providing input for our community, then we need to reconsider why we're doing it. So this is a constant conversation for us. What it really boils down to is an incredible amount of energy and an incredible amount of people, and Todd was very kind. This is not my program. This is Intermountain. There are teams and teams of people and patients and families on the front line that helped us build what we're about to see. But I want you to know that this is really true, that if we don't get this right, we cannot get the outcomes that we want. And it's a constant hassle and pain in the neck to manage the relationships in healthcare and manage relationships with patients and families, but it is also the way forward if we can figure out a way to do it. And the study we're going to share with you is about how we built these continuous relationships over time and produce the outcomes. So just a few notes on why are we talking about relationships? You know, I want to see your data, I want to see your outcomes, I want to see your key indicators. Well, relationships bring value by these concepts. They're the combined efforts of all of us over the full cycle of care, going from the outside of the triangle all the way back there. That's the full cycle of care. Staying well out there is the family's responsibility to provide, to support health care. And then the transaction costs of these relationships is really what costs a lot in health care, not just the procedures and studies that we do. And technology will help us down the road for that. But any one intervention will depend on the effectiveness of the intervention. And when I show you all the people we've had to coordinate, you're really going to get a sense for if you don't have an organized process, there's no way to reduce your transaction costs because they just keep going up and up and up. And then effective and fulfilling relationships for both our providers and our families are really have to do with quality of life. Oh, really quick here. I will be talking a lot about this, and you'll be becoming more familiar with it. Through the process of becoming team-based care, we are really transitioning culturally physicians from doing solo practice with them and their MA, all doing it in their very special way, to a disruptive innovation where we're organizing a team around them, which is more work, more people they have to talk to, more processes they have to pay attention to, and up into these connected teams. And we're going to show you the outcomes of once you go through this journey and get to that place. This was the first picture that Brent James, Dave Burton, and Wayne Cannon, who was then the medical director, primary care doc of our primary care clinical program, where MHI was developed, put together to try to understand from a very early on all the people that were coming into the primary care clinic and who does what. What actually do we need to provide for them for the different conditions? In the beginning, we had only diabetes and asthma, like I mentioned, but as they looked at the data from the conditions of diabetes and asthma, 2/3 of all of the activity on those two conditions, the primary care doc with their MA, they did what they needed to do, and they had these care process models that helped them follow the evidence-based guidelines. But then there was always another 1/6 of the population that needed more, so we added care management and more nursing, more education, and then another 1/6 of the population that needed a specialty consult, whether it be endocrinology, cardiology, psychiatry. And that's how we began to look at how are we going to manage all these conditions. Are there any conditions on there you're managing in your health systems right now that we've missed? And just in terms of history and the impact on primary care, they went to school to learn how to deal with diabetes and asthma and sore throats. And now patients and families are coming in with heart disease, depression, hypertension, ADHD, chronic pain, substance use, multiple conditions. And patients and families, do they have just one of these? No. They usually have a combination. And if you're thinking of just going for that condition, you could be doing care process models for the rest of your life and maybe not meet all of them if they got 5 or more. But if you're going for prevention, there's a lot more you can do upstream to be able to help these families. Data transparency. I wanted to take a really quick note on this because we have a lot of data at Intermountain, and sometimes we forget to share with those that are coming to learn with us that this took many years as well. So we have data registries for diabetes and asthma and heart disease and cancer. We even have one that's being designed for chronic pain. And in our mental health registry that we started in 2000, we have been tracking 604,000 patients for all those years. That's a lot of patients. A lot of patients. And about 164 of them are active every year. And what does that mean? It means they have an active diagnosis, they have an active treatment, either medication or contact with our mental health providers. They've been either to the ER or to inpatient. There's 6 criteria where they're actively being treated within our healthcare delivery system. And this will be important when we get to the data and I show you the results of JAMA. But that is an ongoing way to begin to say, are we making a dent in the population and what's the impact? So when we have a 10-year study we're going to show you, I wanted you to know that we've been tracking diabetes and depression for those 10 years. Those are the 2 conditions that we've focused on in primary care. So a little bit now moving into how does all this actually really work? What is it we talk about? We've got tools, standard screening tools, workflows. We've got a team scorecard, the dashboards, and then who does all that work? So who's really on the team, I think might be important for you. And what is everybody's role? We have leaders that are on the team. We have, of course, primary care docs, the patient and the family, other clinicians and staff, and the role of the community. So there's a role for everybody in team-based care and education that's done across it. And then we'll end up a little bit by the end about really talking about proven results and how do we produce value. How do you actually sustain this once you get it going? Because that's the phase that we're in now, and we've been in it for a really long time. So you just never stop. You just keep going and going and going. So let's go back to actually what's life in a clinic for Emma to the solo practice. a physician that is doing a great job with diabetes. They have the diabetes care process model. They are part of Intermountain's medical group. They are spot on. They're very into quality improvement, but they have not reorganized their clinic to team-based care or normalized mental health as part of the routine of any chronic disease. Emma is 63. She's coming into her doctor. She's got a question about 2 of her 18 meds. She has no energy. She has 10-minute appointments. Are you all still doing 10-minute appointments? Do you know in your health systems? No? Well, someone just told me. Who just told me? Oh, Providence Health System just moved to 20 minutes. I was really jealous. I think we still do 10 minutes. So these are the clinical issues. Who runs the practice? The operations or the business practice? So let's talk about the impact on operations. Multiple chronic conditions for Emma. Her exam's unremarkable for the diabetes that you check on. You talk to her a little bit about, the care process model and what to check for. You answer her questions on the med, and you get up to leave, and you got your hand on the door, and the husband says, got a few more things we're a little worried about before you go. So then what happens? I know there's no primary care docs in here, but if you pretended to be a primary care doc, what happens when you want to leave? What would you imagine this doctor feels like? Well, usually they get a stomach ache because there's several Emmas on their schedule. And this is incredibly disruptive and anxiety producing because then you find out the rest of Emma's story in those 2 minutes before they leave. She's not going to work. She's not sleeping, not going out of the house. She's cranky as all heck. And now her husband's exhausted and he's relapsed. He started drinking again. So now what are you thinking as the caregiver? Should have booked a double appointment. What are you also thinking? You're a pretty good clinician. What's going on here? How comfortable are you dealing with that? Well, we'll show you. What's happening in your business, your practice out there? Remember the transaction costs? Everybody's waiting, and everybody got there early to see you for their sore throat, and now, Emma's, backing up the works. But you are a good doctor. You're trained. You do your suicide screen. You look for options. In our system, our physician would look for options. This is 25 minutes of their front staff trying to find something for Emma. In the past, we'd give drug samples. We don't do that anymore now. Drug samples, the number of the ER, a few people in the community that she could go talk to about her depression, and guess what happens to Emma? She's on her own. Yeah. Bye. On to the next patient. Emma is on her own. And everybody's yelling at everybody, and your staff is just exhausted. So this is not only a problem for Emma, it's a problem for the practice, and it's a problem for the physician. We did ethnographic interviews on patients and families that were receiving care and staff that was providing care in the solo practice, the practice that was being disrupted to move towards team-based care, and the ones that had reached the high level of team performance. In the solo practices, basically, the providers told us, if I don't do it, who else is going to do it? I'm the only one they have. So I'm really being forced to treat these mental health conditions by myself. I don't have any training. I have nowhere to send them, and it really produces a lot of stress and anxiety for me. Doctors are alone. Patients felt the same way as the doctors. I figured it out. I had to go figure it out on my own. We never talked about it. He just refilled my meds. I'm not really quite sure what I'm on Zoloft for. I think it's stress, but we never really actually talked about it. That was why we built mental health integration. And these are the 5 critical key components of mental health integration. This is what we train our teams on, and we move them through solo practice all the way up to connected care over time. Why are there 5? Well, first, Brent helped us organize the 5 key things you have to have in place. But we made mistakes in all of these 5 areas and had to do quality improvement and PDSA cycles and redo until we got it right. Because if any one of these issues was not operating up to snuff, it didn't work. You could not do team-based care. And just to highlight a few of them, leadership and culture. Number 1, and if that isn't up, if you don't have that common vision and leadership on board, You wait till you do. It's not worth the disruption and the anxiety and the money until your leadership has decided. And this means that the champions, whether they're high-level leaders or champion physicians at the clinic, have a core value of accountable and cooperative relationships. Do they want to do team-based care? Do they want to normalize mental health as a routine part? Big question you have to ask. If your psychiatry folks are over here and your primary care is over here and they have no intention of coming together and providing it and they're going to continue to still have turf wars, don't do it yet. Just wait. Just wait until they come together as a leadership team under population health and what's best for their family. The second key component, workflow, the clinical workflow I talked about. The most important part of this key component is engaging the patient. It's not just putting a mental health person in a primary care clinic or putting a primary care person in a mental health clinic. You have to be able to engage the patient on the team and match their complexity to the right level of the team. Where do you see all the people we have to figure out who they're going to go to? How are you going to know where they go to? That's clinical workflow. Information systems is your registries, your data, your EMR, all of the way that your teams are going to communicate with you, and how are you going to give them feedback. Financing and operations. This is a huge challenge to us. And it started in 2010 when Dr. Leckman said, this is the way we're doing the medical group, and operations leaders, this is on your portfolio. We are doing mental health integration as a business, and it's on your job description. And until those operational people got on board and helped us with their expertise on how do you staff, how do you budget, how do you run a clinic, all those things that doctors and providers don't know how to do, they're the clinicians. You need all the people, really working up to their level of performance. In financing and operations, we built a team FTE, which means a combination of all the people that have to be there. And then the fifth key component is you can't possibly provide all those social issues we just talked about. You can't do everything. So who in your community are you going to partner with to help you link up patients and families to resources out in that big part of the triangle to stay well? So all of that is really the core key components of what is the mental health integration program. It's all 5 of them. And it's a standard clinical and operational team relational process, and it incorporates mental health as a key component of well-being. And it's a routine way to normalize it over time. Whoa, look at all the people that you have to coordinate. This is a lot of people in a primary care practice, which you already know because you have practices that are running. This clicker doesn't work. So what I'll do is just point. At every clinic, you have a primary care doc, patients and families coming in, and the front office staff. That is the inner core of a lot of activity of what's happening in healthcare on a daily basis. In the next circle, the blue circle, we've added more staff based on the complexity of their population to support that inner circle with managing the right level of chronic disease. On the outer circle are people either in Intermountain that aren't at the clinic, so there could be our own physical therapists or nutritionists that work in the hospital or other places, or it could be the community at large in terms of who we have to link up to. But this is the core issues of getting what team-based care means and getting all these folks organized. It's organized around the primary care doc. It's managed by the operations director. So there's an operation and primary care doc that are working hand in hand. Everyone does standardized training in a holistic care plan that has measurable outcomes. Outcomes are attached to every care plan. There are care process models that are followed. But as you can see with all those chronic conditions, you could activate any one of them. But they're linked to the EMR. So having a way that your evidence is linked to your EMR so that we can remember and we have reminders and alerts. And then the disease registries are there and patients having access to members. This is what team-based care is not. It is not co-location and just putting mental health staff. It's not going away. So it's really been the way that we've been able to rejuvenate our overwhelmed primary care and say we're just going to continue to support you and figure this out, because the chronic conditions have not gotten less. They've gotten more and more complex. And it's also not something that everybody does in their own special way. This is probably the biggest cultural mind shift for us as providers, because we are experts in doing our thing, interpreting the information, using the guidelines the best we can, but we still do it in our way. To actually come together with your cohort and with your teams and begin to come with our way and actually go through a peer review process on a daily basis of are we all on the same page is new for primary care and other specialty cares as well. So we like to show this picture, again back to our ethnographic interviews of staff and patients, to all the clinics that are starting out. Because all those solo practices, all the staff think they're doing team-based care. When we say how many of you are working together as a team to reach goals and help your patients reach their outcomes, and we give them a definition of team interactions, all the staff. Patients aren't experiencing that. They're getting a little bit more here because we've disrupted the flow. We've put more people in their clinic, and there's more people the patients are actually getting to talk to. But it's not really till you get to that high routinization and all those 5 key components are happening that both the staff perceive they're providing team-based care and the patients are actually saying, yes, I got linked up, I got connected, and they were focusing on me. The Sarah story that I told you earlier. Busy slide, but let me point out 2 things of actually building the teamwork, because it's around 3 core outcomes. Quality, and this is familiar to you all, the triple aim. Quality, cost, and patient and staff experience. We include staff experience on the end there too. These are the operational pieces of the outcomes driving the teams working together on that. The triple aim, the care processes models help you get there, and then those essential 5 elements of the team having to work on those all the time. The standardized training and screening is the next key part in that workflow element that we do, of really being able to understand what is the standard process and care process model for mental health integration. We have condition-specific care process models for all the conditions, ADHD, diabetes, hypertension, depression, but the MHI care process model is the first team-based care process model of how do you put all that together and who do you actually put on the team to be able to help you. The way that we organize that is we have a standardized screening and then a standardized basically mind-body scan that helps organize the patient's story. How complex is their story? How complex is Emma's story? I'm going to walk you through Emma's story. And then who on the team is the right level of combination of people to help her and her husband? The teams have a scorecard and a dashboard that measures their level of team performance on a yearly basis. So they're measured on those 5 key components. I will share with you a little about that. And then we have ongoing team huddles and difficult case conferences for providers and teams to be able to come together in their regular medical home, we call it personalized primary care, medical home meetings to be able to discuss complex patients that aren't getting well or aren't progressing, or to look at the list that patients are falling off or not falling off. Lots and lots of interaction there. The other part of the standardized training that we had to do in the very, very beginning, and we continue to do now, is really help the providers and the staff with their exhaustion of having mental health normalized in a primary care clinic. Just to say we're now going to do mental health, what do you think that did to the clinic staff there? It raises an incredible amount of anxiety for them. Patients who are suffering from mental health, whether it's a social issue or a specific condition, come in with incredible affect and relationship styles that can be exhausting and not familiar to your basic MA or primary care doc that doesn't have a lot of training. And so what we began to realize is that these families that we used to call difficult to treat or non-compliant, now we just are ready for them. We have very nice things to describe now. They describe it for us, actually. We're leaving our physicians exhausted, confused, apathetic, and very, very vulnerable to stigma. I don't do that. And when we interviewed the MAs say, we don't want those patients here. Those patients should go somewhere else when we interviewed the MAs in the solo clinics. And so we decided to begin to train them on how do you engage in a helping relationship with someone that's suffering, that's had a lot of adversity, or that's not feeling well, or that's cranky all the time, or maybe mean to you. How do you actually do that? So we provided support, consultation, and we have a family pattern profile that we use to help establish meaningful relationship goals. Because all families and patients engage in a helping relationship and ask for help in different ways. And this isn't just because they're sick, it's just their natural way of asking for help. And we try to engage them in that. We ask them, who do you most commonly go to or talk to when you don't feel well or you're distressed? And if they say, I don't talk to anyone, I like to do things on my own. We don't judge that as, oh, well, we're not going to get too far with you. We say, okay, let's understand this. And these are patients that need a little bit more support. We also have families that come in that are very confused and are all over the place. And they have many, many, many problems, and they exhaust the staff. And they're calling the MA every day for medication changes, and they're showing up with multiple family members, and they're fighting in the waiting rooms. This is an exhausting, and your physicians are saying, I don't want to run a mental health clinic here. I want to run a health clinic. Getting all of that normalized and organized in a way that you can actually understand it is really the way that we actually engage and understand. The families tell us their natural style of engagement, and we understand their style and then use it as our way to follow up and engage them and match our care management plan to it. This is the core of the first working group of the team allocation. In that core, the patients have a role. They fill out the information, they do the screening, they fill out the mental health packet, the body scan, mind and body scan for us, and they tell us what's your natural way of, how do you want us to engage with you? And we match that to their preference. They get involved in the treatment decisions, self-management, lifestyle changes, follow-up, but they have a job on the team, and we encourage that, and we have a really nice brochure. The primary care doc does all the things they're really, really good at and a couple of more really critical things. If they do not prepare the patient and family for team-based care, and that's a normal part of the function, it doesn't happen. The family doesn't want to talk to the care manager. They definitely don't want to talk to the mental health person because they're not crazy. And they definitely don't want to talk about any of this stuff. So the primary care doc has to introduce the team, introduce that they know what they're doing, they have support around to do it. Screening, diagnosing, using the tools, and then they are the champions and the quarterbacks. They activate the team members that need to be activated based on the complexity of the patient's story. And you'll see that happening with Emma. The story I read you in the beginning, this is happening all behind that patient's experience. She's engaging with a physician that's doing all of these things. The MHI treatment cascade is how we organize the patient's story, their self-report, their qualitative information, not just the number of diagnoses, number of visits, number of that. We got that good data too. But we want to understand how complex is your story. And if the patient completes this information, are you sleeping? Are you eating? Do you have chronic pain? Do you have a family history of mental health? What is your PHQ-9? What is your family engagement style? Are you isolated and don't want to talk with everyone? All of that's organized. And if that actually falls into, hey, things are pretty good here. You've got a really good family support. PHQ, your depression score is not that bad. Your diabetes is under control. The primary care and the MA, those core groups of team members can manage that. You don't need to call in more resources or send the patient to more people if you can manage it. 80% of the mental health care in our clinics now is provided by this team. That's the core team unit by primary care. Then if things are a little bit more complex and they fall into the moderate complexity, let's say Emma has diabetes that's out of control. Let's say she has a really high score on the PHQ-9 and not as really at high suicide risk, but she has thought about it once in a while. And she has an exhausted family support system. She's burnt everybody out. No one wants to talk to her anymore. Minimum standard there is you're going to pull in your care manager to engage her and help her understand her style. You might even have a mental health consult with someone that's actually in your clinic. You may just look at a packet and say, yeah, let's do this, that. You may decide together, no, I want to have a visit. Or you as the physician can say, go right to the MHI provider, tell me if you agree how complex this is, and then let's decide together. Multiple combinations. And if it's really high complexity, there is a burden risk. And you are nervous, and you are over your head, and you've got your team there that's going to say, yep, you're over your head. We don't have the right diagnosis here. We don't have the right meds here. I need to see this patient face to face, whether it's our psychiatrist or our talk therapist. But all of them together, that big circle, they make one critical decision in that bucket. And I'll show you the outcomes. Can we get this patient and family well in primary care? And if the answer is yes, then they stay with the team, huddling around them to get everything right and get them stabilized. They don't have to go to the emergency room. They don't have to get hospitalized. But some patients do. But you have a team to help you make that decision so that's not a first trigger reaction. High specialty, you want to go see the specialist. It could be detox. It could be inpatient. It could be to the ER. Then that was an appropriate use of that smaller end of the triangle. Any questions on that treatment cascade? That making some sense? Okay, great. All of the data, like I said, falls into a care planning worksheet. And what you're really doing here is helping the patient, going through answering this packet is like reading your own x-ray. Well, what's my risk? Am I sleeping? Am I not sleeping? Oh, yeah, do I have this going on? Do I have that going on? And then what's my current status? What actually, am I scoring depressed on this depression score? Do I have anxiety? And then a working diagnosis that you go over. What are the working diagnoses we should be teasing out here for you? And then it falls down into the mild, moderate, high complexity. Here's your treatment choices. You and I could continue to go over here. I would like you to meet my care manager. I'm concerned about this. I actually have a mental health expert that's part of my team. Let's get some more information. Let's put that together. And it's a conversation, a co-production between the physician. Those are all the people there that are called in. All the data gets put into the EMR. We're using technology and data to help connect all these people. But the clinic manager is the boss. And we're going to get into operations in a minute. How do you keep everybody on the same page? The clinic manager ensures the standard workflow. She sets expectations with the team members. I can't tell you how critical this person is. And one of the things that we learned over the years is that if this person does not own the process, it doesn't happen. There's no way physicians can work this process of a clinic. It has to be owned by someone, and they have to feel really, really good about it. Like, I can do this. My clinic's going to be routinized. And when you get people kind of on board to be able to do that. They act as a resource and a support to all the team. Does the MHI provider have what they need? Does the care manager have what they need? Do my physicians have what they need? How many MAs do I have? They have to deal with turnover. You have somebody come, somebody leave, and they all have to get trained. They are in charge of scheduling the routine meetings to come and talk about complex cases, and they monitor the efficiency, the operational outcomes. We have operational outcomes that they're responsible for. The care managers, this is the glue. This function is the glue of any team-based care, wherever you want to start. If you don't have this, it's going to be impossible to do. We started with one care manager, an RN nurse in every clinic to manage chronic disease. We now have 5 people providing this function now because the function was so great they were getting exhausted and burnt out. They provide engagement, education, they monitor the care plans, the disease, they do team huddles and outreach. You have health advocates that are really advanced MAs, the doc and their MA, but they're looking at the list for the day and they're checking the schedule and they're looking at the data. You have care guides now that help patients navigate the social system, and we've actually added social workers here because the social determinants are so huge now in our clinics that they're actively really good at reaching out for housing and transportation and all of those issues that families need to get to. Our therapists provide excellent talk therapy. They use evidence-based tools. They provide diagnostic and evaluation and training for our teams and a consultation role. They do not start a private practice in a primary care office. They are available on a regular basis to team huddle, to do trainings and education, and they do solution-focused therapeutic interventions for patients with chronic disease and CBT. They review the packets and use the packets, and they participate in all the core issues. They are actually at the clinics more than our psychiatrists and nurse practitioners, and they are great buddies with our care managers who work together on many of the team roles. You're here, Travis. Do you want to say what you do in the clinics? Or do you want me to just do it? Okay, all right. This is what Travis does. And we're really excited because we've attracted more psychiatrists actually to work in our medical group because of the team-based care model that actually want to be part of the system that's doing that. The psychiatrists and APRN are expert diagnosticians on complex medical and psychiatric. They also consult on medications, and they do not write the scripts. They may help physicians start the scripts, but the scripts, the follow-up for the scripts, are done by the primary care doc. Why is that? Because psychiatrists may only be there 2 hours, they may be there 4 hours. They're managing multiple clinics. We don't have a full-time psychiatrist at every primary care clinic. It's a team FTE. You have your talk therapist there, probably 8 to 16, depending on depending on how big your clinic is. Then you have your care manager there full-time. You have your primary care doc there full-time. And remember, everybody's doing mental health. So you need a psychiatrist based on the complexity of your population. And in our pediatric clinics, we thoroughly encourage them to have a psychiatrist available, either virtually or by phone or there, because we don't want primary care docs diagnosing bipolar. We want them to understand it. We want them to help us track the medications and provide it, especially if they're even in the mild complexity. You could have those serious illnesses but still be doing well. But our psychiatrists are there to train our docs, build almost like a mini residency of you can do this, here's what all these complex factors mean, here's how you engage patients, here's how you talk to cranky patients, here's how you understand countertransference when patients are projecting all their mental health issues onto you. They're there for support when things get really anxious and worked out. They're also excellent in clinician and staff education and basically doing like daily grand rounds, talking with physicians as well as seeing patients. All of our mental health providers are there on a 70-30 productivity. 70% is seeing patients and actually billing in our fee-for-service market, but we pay them 30% of the time to be there and have team time, where they're actually interacting and doing that team time. And mental health providers are also involved in the scorecards and in measuring their team performance on those 5 key elements. So you put all that together and you have an incredible team-based care opportunity, but you also have your community resources. So you need to know who else in the community could provide family support. And at one point in the very beginning years, it fell apart probably over the last 3 years. We used to have NAMI, which is, are you familiar with National Alliance of Mental Illness? They actually helped us build mental health integration. They were on our leadership team. And their trained folks would come in and actually train our care managers. Here's how I want you to talk to me. A schizophrenic patient was training our care managers. Here's how I want you to talk to me when I'm hearing voices. A suicidal patient would train our nurses and care managers and even some of our mental health folks. Here's how I want you to talk to me when I'm suicidal. And here's what it's like for me as a patient. It really decreased the anxiety to just talk to people that have mental illness or family members that do. And they have an incredible program, Family to Family and Hope for Tomorrow, that are still operating in some of our primary care clinics. But as life would have it, their leadership changed, and we were never able to really link up those NAMI people becoming part of the internal team. They were still the external team. And being able to collect data and information and share information back and forth became very difficult. So it's something to think about as you're building your community resources is how are you going to communicate, know that they actually got there, that the resource was useful and helpful, and build these partnerships over time. So now let's see what happens to Emma. She heads into that office. She's already been screened with the PHQ2 and PHQ9, so the physician already knows that even in this 10-minute visit, there's something going on. They do a suicide risk. You say, Emma, this is really important and I can help you. You explain the team. You give Emma and her husband this packet to get more information, and please come back. I want to see you back. Emma and her husband leave with treatment started. Mental health treatment has started in that 10-minute visit. She did not have to go somewhere. She didn't have to go make a phone call. It was normalized right there and say, you know, diabetes patients, many people suffer from stress and anxiety. Let's make sure that this depression is not going to complicate your blood sugars. Maybe that's what's going on. Let's figure it out. It's a very, very comfortable way to talk about it. Physician goes and sees their next patients, no more delays. You send a message to your care manager through the EMR. Please contact this family, see if they have any questions, if they need any help filling out this packet, and please have them bring it back. And you can decide, I want you to come back and see me, or you may want them to go right to the mental health expert that you have there. The packet comes back either on paper, and we're moving it to being online, and you review the packet, and you determine the complexity, and you activate the right team members that you're going to need for the next appointment. And this happens iteratively over and over and over again. So you have a partnering care plan that's driven by understanding the patient's story. And the patient tells their story once. Not every person on that team, they have to go to every single person and tell their story all over again, which is really, really burdensome to patients and families. Why can't we get it right the first time they told us? And this standardized training and process of gathering their data and their story is in our EMR. We're all on the same page, and we don't ask multiple questions over time. Now, when they get to that specialty bucket, there may be more things we have to ask. We may have to ask more things on pain. We may have to ask more things if you're in the outpatient psychiatry, or if you're in an OBGYN clinic, or that. We build that in. So let's talk about what happened with Emma. She filled out her MHI packet, and it was determined it was moderate complexity. Her sleep's not doing so great. There is a positive family history for depression, suicide, and bipolar. She's actually at risk of losing her job because she's not been able to function. And she's also scored herself as having a very avoidant engagement style. She does not want, she's very isolated. Positive history of sexual abuse that she's saying is affecting her now. She's got a pretty bad PHQ9, and she's got a positive bipolar screen, which needs to be validated. She doesn't like taking medications, and she really doesn't want to talk to anybody about her problems. Where do you start in the partnership with Emma? What's the most important variable on that list of key findings that you as a team, you as the primary care doc need to do to engage her in a partnership for her health? Anybody want to take a guess?
What are her goals?
Pardon?
What are her goals?
You could ask her what are her goals, but this is the information she gave you. These are your key findings. You're going to get to her about her story, her goals in a minute. But even to have a conversation with her about her goals, which is great, what's your biggest issue you got to deal with and acknowledge with her? Isolation. She doesn't want to talk to anybody, and she doesn't take meds. She could be depressed, she could be bipolar. How am I going to get her to Travis? Oh my gosh. I don't like taking meds or talking to anyone about my problems. That's your first conversation you need to have with her. And now you can have it because she just said, this is my natural style. And you can say, got it. I understand that. But now I need to talk to you. When patients have this avoidance diet, I need to give you some facts about these illnesses you have. That's my job. That's me as the expert. Depression, diabetes, positive bipolar in your family. We've got to figure that out. You use assertive, proactive PCP contact. You may be the one to engage your care manager, your MA, your front office, whoever they're the most trusting with. And you match that to her self-reliance. You need to let her feel like she's in control, even though she's got these serious conditions. and introducing the care manager might be the first step that you do and educate the team over time. When we've been able to have this full picture of Emma's story, also we asked patients when they come into their primary care visit and the staff, tell us what happens. Walk us through the steps from the minute you start talking about this mental health issue till you actually have an action and you've done somebody's done something for you. The patients and staff all agreed on 7 things. My doctor explained it to me. They screened either using the PHQ-9 or the packet. We talked about results. We discussed options. Meds were started. A team was activated. And there was a documented follow-up plan. When you were in those solo practices, what did all the patients get? Patients all got meds from their self-report. Staff thinks they're doing a little bit of all those things. Patients are getting a little bit more of the key processes, but it's not until you get those teams performing at that high level of team performance that what we trained our staff to do, all the team members, that the patients actually said they got it. And the 2 that jumped out at the most, which I'm hoping you're seeing, is talked about results and discussed options. I mean, there's many nice colors on there, but those are incredible outcomes to be able to have in primary care. So here we have an integrated systems of care, these 5 key components, doing them all over and over and over again. How easy do you think this is to do? This is a gift from our operations folks. My favorite operations person presented this at a, oh gosh, go back. Let's see, how do I actually get in there and do it? Ooh, is there any tech people here? Wait, hold on.
This man right here is my great-grandfather. He was the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here. And if you look at his face, it's just ripped to shreds, you know?
You see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
That's really what it's like. So I just want to give you a feel for, it sounds great, I'm going to show you some great outcomes, but this is really hard work, and we have a lot of great people that do this, don't you think, Travis? This is our operation guys every day, and they're trained to do that, by the way. Okay, so how's everybody doing? Now we're going to get to data and results. You ready for that? Okay. Here are the reporting tools and standard data. So we have a standard clinical, we got standard everything. Everything's way over standard. But we have tools that we've developed over the last 15, 18 years that help us move those 5 key components together. We actually do a complexity analysis on the practice, the volume of patients that are coming in, how many medical conditions do they have, what's the payer mix, how much mental health is actually being billed in the clinic already. We have a staffing analysis, a formula we've built for that. How much psychiatry do we need? How much care management do we need? All based on the specialty, whether it's internal medicine, family practice, OBGYN. We have developed a scorecard. Those 5 key components are measured every year. We have the outcomes. We have NOIs. Every clinic gets their NOI every year. Did they use the resources appropriately? And did it actually develop in any cost offsets? And then we have longitudinal measures and staff experience. Why do we do this? Because we have an incredible data structure at Intermountain. So if you don't have this data structure, don't get depressed. It's worth using whatever you do have to be able to build the story, but you do have to build the value story. But we have an information system structure that allows us to pull all this information and actually produce the study that we did in JAMA. The clinical financial claims, the scorecards, the patient's data, ED visits, hospitalizations, and then we have a practice management suite that our operations people that are herding the cats can look at it and go, how am I doing? And they can look at it on a regular basis to be able to see that. Clinical decision making. I spent a lot of time on leadership and workflow and how you actually build the clinical decision making to do it from the patient story. Goes into our EMR. That's not what it looks like now. That was our old EMR. It gets inputted, builds the data registry, which I already shared with you, and then reports go back to the team so they can have feedback on how well they're doing, managing their hypertension, their diabetes, their depression, and any other issues that are there. In the very beginning, even if you don't have that, this is all the data we had for Dr. Leckman. We basically had clinics that were doing MHI and non-MHI, and we had staff satisfaction before and after, physician satisfaction before and after, which was positive in the MHI clinics, and then patients were satisfied too. My physician is sensitive to my emotional needs. They explain things to me. Whoops. When Dr. Leckman saw this data alone, before we all have the data I'm going to show you now, the fact that she had happy physicians, that she's engaging in a medical group, she said, put it everywhere. I don't care what it costs. I was like, really? Now we care what it costs because we know what it costs. Patients' PHQ-9 scores were getting better. In 2010, we published the results of patients that were in those highly routinized clinics that had only depression from our health plan. And they were in, compared to the ones that were in non-MHI clinics. They were in the ER 54% less, and we saved our health plan an incredible amount of money on all medical conditions. When we interviewed the staff and said, okay, what is this MHI on the front line? Again, our ethnographic interviews. The key things was an organized process, which I showed you is happening when it gets to the routinized level. They had support. They felt empowered to provide better, but it was a regular expectation. So all of those things are things that staff are feeling in terms of why it's different on the front line. Here is our scorecard. In the planning phase, we work through all the issues in those 5 key elements that they need to be focusing on. How complex is your population? Who's going to be your leaders? The workflow. Looking at the measures, tracking them, and inventorying their potential partners. In the adoption phase, we get ready for them to be resistant and think we ruined their life and we're trying to make psychiatric clinics out of them. But we still give them data and we show them. We actually give the staff support and people that are there. And then routine is basically normal life. And right now when you get to that level, we have our physicians saying, we will not run our clinics without our lab and MHI. So even in all the turbulence and issues that are happening in primary care, they are not willing to give up MHI. And I think that's an important establishment of it's no longer an innovation. So the key factors are you have to have a primary care champion if you do this in primary care. The practice manager needs to own it. Each team member that we talked about needs to understand their roles. The receptionist, the MA, the patient and the family, the janitor, people you would not normally talk to about it. They're all there at that clinic working really hard, and patients are walking through and getting their care from the entire team. And then if your process does not create these 3 components, we tell our clinics, start over. And there have been clinics where we've taken the resources and moved them to other clinics because they're not performing. And you've got mental health people that are there that are not busy. Their schedules aren't full, or they have you can't get in to see them. And so it's a constant conversation of, do we have the right mix? Do we have the right fit? Are people actually providing team-based care? So we were very fortunate, again, to have started this in many, many years ago in 2000. And we decided to actually provide for Intermountain as they were moving towards developing their strategy for population health to decide what was the return on investment for doing this for so many years. And since we had patients in such an incredible data registry, we took patients that were treated in our medical group between 2003 and 2005, and we identified about 500,000 patients, both children and adults, that were treated in all of our clinics. And we said how many of them stayed with Intermountain for 10 years. We wanted to know the impact of having a continuous relationship with Intermountain and being exposed to team-based care, which we had invested in. What impact did that have on their quality outcomes in terms of their clinical outcomes? And what did they have on cost? And what did it have on patient experience? For the cohort that was the adult cohort, we had about 130,000 patients. So half, 200,000 of the 500,000 were the kids. We're studying them now. But 130,000 stayed with Intermountain over those years. In 2010, when Dr. Leckman put the operations people in charge, we also added medical home to our mental health integration team-based care process. How many of you have medical homes in your system or in your community? Okay. What was the medical home? What was added? We had more care managers. We had more health advocates. We had incentives that our health plan paid to our physicians to continue to work in a team-based care process. We had incentives for the practices to build into their metrics some of the NCQA accreditation pieces. Our medical group decided to put the medical home in clinics that were already doing really, really well with team-based care and had reached that routinized teaming process for normalizing mental health. So we adjusted for that at 2010, and between 2010 and 2013, we considered that our team-based care study cohort. And clinics were measured on a yearly basis for their level of performance of team-based care. And then we tracked the outcomes. Oops, it's 2016 now. We're still doing that. This is how we measured how teams were high performance. So for that 130,000 patients, we certainly had enough patients that were being exposed to no team-based care, planning it, adopting it, and those that have reached the high level. And we wanted to see the difference between not having it at all and having reached that high, because we know in between was the disruptive phase, and people were in and out. We wanted to know if we spend this and actually get people up there, what would be the difference? They received an MHI scorecard, which I just showed you in terms of routinization, and they also received an NCQA level 1, 2, 3. The characteristics of those combined team-based care performances were physicians were engaged, they were attending meetings, they were running meetings, they were looking at reports, they were activating the tools. Care coordination and established protocols were being followed. Patients were getting care plans. Monitoring tools and EMR, the reporting tools were getting measured. There was operational efficiency and monitoring. So the clinic managers and operations folks were measuring the teams and making sure the staffing was there. If people left, people were put in, people were trained, people were educated and onboarded. And there was outreach to family and community. Those were the characteristics of these high-performing teams. The other teams were basically like you saw what Emma had early on. They received a score. We looked at them for 10 years, and the patients that were exposed to the high level of team-based care and patients that were exposed to what we call traditional practice management. We had 113,000 patients that participated in this study, which is the largest study of team-based care that's been done in the country so far. We had 113 primary care providers. 27 clinics were at this high-performing team-based care level, so keep that number in mind. 75 patients were also received care in 75 clinics that were at traditional practice management. But they were still part of the medical group. It was organized. They're part of Intermountain. We do quality improvement. We have great leadership. We have care process models. But remember, it was still solo docs doing their care process, quality improvement, on their own without a team organized around them. If you were treated over those 4 years and exposed to those 27 clinics, you were screened for depression, which meant it activated. These are active patients in our depression registry with a PHQ-9, not just the 2, PHQ-9. And that activated our depression care process model. So there were people in those clinics that actually got activated and supported to help them, like Emma was. If you were in those 27 clinics, you had a documented care plan compared to the other clinics. And these were care plans, like I mentioned earlier, for diabetes and depression. If you were in those 27 clinics, the likelihood that your adherence to your diabetes bundle, the 5-part bundle, was greater. So patients were actively providing self-management and self-care for a chronic condition. We can send you the JAMA article. A control in the JAMA article is that hypertension was not different. It actually looked a little better in the usual clinics. Anybody want to take a guess why that might be? Hypertension did not become a goal of the clinics till 2014 when this study was over. It did not get into the machinery of team-based care and quality improvement till then. Something else to think about. We focused on depression and diabetes for 10 years. We got results. So there's only so much a system or a group of administrators can focus on. Pick your priorities and understand what they are, and if you can focus on them and not have too many of them, it's really, really helpful. If you were in those 27 clinics, you weren't going to the emergency room, similar to our other study. Now, this is the entire population of patients. This isn't just diabetes and depression patients. This is the entire population that was seen in those clinics. All payers. This is not just our own health plan. This is uninsured. This is commercial. This is Medicare, Medicaid, everybody. This is the entire population. You weren't getting admitted to the hospital. And you didn't have to go see your primary care doc as much because you had people, care managers doing outreach, or you were self-managing yourself. You stayed in that higher level of the triangle that I showed you earlier. We reduced costs to our health system as a whole. And remember, it's our whole health system. We got hospitals, we have the medical group, and we have our health plan. We were also able to account for how much did it cost us to do team-based care. All the care manager salaries, all the mental health salaries, all the incentives to the primary care docs, all the administration, my salary, research salary, everything that was involved in mental health integration and team-based care cost Intermountain $22.19. And we saved $115. So what do you think was the first question from the chief financial officer when they saw these results? Remember the number 27. 27? Are you kidding me? That was only 7 to 8% of the entire population of patients coming into our medical group. We have 185 clinics. 27. Why do you think it was only 27? Well, you just have to think about herding cats. It is really hard to do, and it's hard to scale. And we're working on technology. We've hired more staff. We have operations. It's a constant work in process of being able to have those 5 key components and having leadership be able to be actually committed to paying attention to it. This helped. This helped re-energize our leadership. It helped re-energize our medical group in terms of we are definitely doing this. This is how we're going to do business. We were able to hire folks like Travis. We were able to bring in more people to help us build it and scale it. So you have to have the data to show it. You have to have some way to build your story, not just the patient story, but your data story. All patients was $115, but even if you had one chronic condition, it was $191. And if you had 5 conditions like Emma or someone else, it's an incredible amount of opportunity of savings to be able to consider to put all this together. This is the underpinning of those savings. These patients were exposed to continuous relationships over time and multiple team touches. And it was all patients that came in and were exposed. They stayed loyal to those clinics. They stayed there over and over again for all their health needs. We caught them early, and they did not get sicker. That's really what the savings was about. But the reality of it, and this is the editorial to our JAMA study, is that even though this is the best thing to do for Emma and her husband and every patient that goes to our clinics, and the editorial actually went as far to say it's unethical to triage patients with chronic disease to any other type of care, the resultant financial benefits did not go back to the practice that made the changes. We took money from the hospital. Primary care docs and administration of the medical group did all the work, and we saved our health plans money. That is the financial reality of how hard it is in a fee-for-service market to do team-based care, even though we now have the evidence that it is the right thing to do and to move towards. What we are doing at Intermountain and moving towards population health is moving as a global payment, a way to be able to enforce. So now we are encouraging our primary care physicians to have paid for quality and moving from volume to value. Are we there yet? No. We still have many, many physicians that are on work RVUs and earning their living that way, but we are moving towards this. The key social factors that we talked about early, I want to circle back on that before we wrap up, is really focusing on, in these clinics, patients are able to say, these are the outcomes that are important to me. I want to function better. I want to be treated normal. I want to be connected to a team that talks to each other and follow up and find a solution. And when we're on the same page, we're all happier. In 2017, last year, we won the Hearst Health Award for this approach and this population because we have been able to reach all these outcomes and actually share it with partners across the country and global partners actually abroad. We brought all our teams together and had a nice dinner for them and gave them the reward and gave them plaques and recognized them for all their hard work doing. This is really, really important when everyone's working that hard, is to take time out to recognize them and have a way to reward them. Every year we have our mental health integration retreat. We bring our teams together and we look at the latest science and how are we doing here and how are we doing there. But it's really good to stop and have people recognize the hard work, and not only just for the outcomes, but for the effort that's being put into it. This is Sweden's slide with data, and just something for you to think about as you're moving forward to building value. I showed you the results. In the green are how many patients now are exposed to team-based care in our clinics. So we have over 185 clinics, about 120 of them are in some level of team-based care or moving toward it. In specialty care, we have OBGYN, we have sleep, we have diabetes. We have multiple specialty care clinics that are now moving towards team-based care. But we still have some clinics in primary care that aren't team-based care, and then as well in specialty care. The $13 million in savings is the savings we could potentially estimate for all the patients that came into our medical group, which is about 1.2 million, if they were all exposed to team-based care or had team-based care access. Utah actually has a population of 3 million, so all those people we're trying to keep well out there. We're looking at virtual team-based care where we are digitizing our MHI science to expand it out to patients in the population. They don't have to come to the office, or they can just stay out there and be well, but have the tools and the science to support them. But we still have a huge headache that I'm sure that you have. We have about 300,000 patients that come to our ER. That's where they get their care. We can't get them attached to this network here. We can't get them to be here for whatever reasons, multiple social reasons, multiple cultural reasons. That's where they feel their care is. So we have to be thinking about redesigning that aspect of it and building community life. So this is kind of where we're moving and trying to really redesign how do we meet patients and families where they perceive value. And that means having partnerships with patients and families and having them help us build it. There's a lot in that blue area that Intermountain is brand new in getting involved in because we've been so focused, probably like the rest of you, in specialty care. And at least we've had a very robust medical group. We've been in ambulatory care for a long time, which is why we are able to do this study. So what happened to Emma? Emma went back to work. She's now following her diabetes plan. She's going to AA meetings with her husband. She's got an improved mood. She didn't have bipolar. Good thing we got the right meds going, huh? She's considering actually, even though she has an avoidant engagement style, she's building some relationship competencies within that. She's considering participating in a support group at the clinic because she's become so comfortable there. There's other people there that have the same issues she has. And she can text her care management team, and she doesn't actually have to come to the office as much. She's part of that group of patients that are coming actually less for their questions about their meds. What sustains this MHI engagement and team-based care? There are four key principles. We have been able to figure out how to have a complementary division of labor between all those people. It's not anyone's job, it's everyone's job, but you have to have some way to divide up the activity and tasks that we have to do in healthcare. That builds a sense of equality and not being isolated. We have a common understanding that we're all in this together. We are going to normalize, we're going to work towards overall health, which includes mental health. That builds respect, that everybody on the team has something to offer to make it happen. That's respect. That makes you like your job. We have a common knowledge. If we all are going with Emma's story and have a common knowledge, and we are using the appropriate care process models and the standard line of thought, and we agree on diabetes, and we agree on substance use, and we're going to try these best efforts, we're going to improve our quality. And we're going to reduce uncertainty in terms of healthcare and transaction, and that's what builds the valued exchange and the actual outcomes and savings down the road. So just to wrap up, I want to share with you what patients are telling us matters most to them to reach their outcomes, not what we do, but what helps them reach their outcomes in the way that they define their health and getting better, is they want to know that we care. They want to know that we heard them. They want to know that they can trust us and that we're competent. So how do you know if your doctor's competent? I can tell if they're reading those journals. You know, our patients are smarter than sometimes we think they are. I want to stay well. It matters to me to stay well. Whether any of these patients that we interviewed had been managing depression for 10 years, chronic pain, obesity, rheumatoid arthritis, many, many conditions, they did not define themselves according to their condition. They defined themselves according to function. Can I work? Can I stay well? Can I spend time with my family? The same way we define ourselves. They did not see them as a diabetic, as a depressive, as that. They come into this looking and wanting to stay well, even though we would be like, oh, 10 years, oh my gosh, you must be having a bad life. You've been depressed for 10 years. Well, some people are depressed for 10 years and having a really good life because they're stable. And we matter. We miss this all the time in healthcare. We focus on the individual patient and we do not focus on their family. Could you please write my family a note and tell them why I have chronic pain and I can't come to family dinner? You know, like teachers, you write notes for teachers. Could you please explain my diabetes to my family? Could you please come in and tell them about these meds? I can't process all this information. We leave families out there, and you know, some of us have good families. They walk in and they sit right there and they're there with us. But many people don't have that, or don't have a social network that we include to kind of help understand and build that social support around them. What's value to our patients is to getting to the root of the problem, making it affordable and successful. But the job's not over, so ongoing, and I love this last thing, the key factor of our health is the health of others around us, so we really need to move out into the community and to families and to build that. We have many people across the country that are using our MHI science and are implementing our process, and we are learning from them. And we have many, many countries that come here to visit with us and are adopting some of our MHI. We're now putting it into a digital form to make that a little bit more easy to scale and monitor. These are just questions for you all that I'm going to give you in just a second. These are the platforms of our assessments. We're digitizing the patient's assessments. We are also digitizing how we measure the complexity of the practice, building in some data reporting and structure, outcomes tracking, and then there'll be a virtual team. In some of our rural communities, we don't have the resources that go there. There'll be a virtual team that will be part of their team but they will be able to contact them when they want them. They will have met them and have relationships with them, but they will be available remotely. But they will operate as a team, a whole unit, a team. It's not just telepsych and you go in and you talk to a doc that's on a telepsych. It's an actual virtual team. So I have a video I want to show you, but my take home for you to be thinking about is that we've shown you the business case, both for patients and providers in a system, but mental health is everyone's business. And it's no longer something that we can't be talking about. It really is something that we should take to heart and actually think of it as something that will help us improve health care and get to the heart of things. So let me now try to share with you one last video, and then we'll have time for questions. And I'll go back to that other slide.
Creating a system that was financially sustainable.
There we go.
Writing a script wasn't enough. Telling someone they have diabetes and telling them to improve their diet was not enough.
Offering a patient education handout wasn't enough. Referring a patient to a mental health provider with little or no follow-up wasn't enough.
Adding a few mental health providers to the practice staff wasn't enough.
Mental health integration is a solution for the inadequacies that patients and providers face in a healthcare system not designed to promote wellness or care for the whole patient.
So the challenge that Intermountain was facing, our physicians, our patients, was access to mental health support. So in 2001, we came together and asked a pretty simple question. How can we do this better? How can we improve access to care when people have a mental health condition? Out of that came mental health integration. And this was set up in such a way that we could learn as we stepped through the process. We could continuously improve. What mental health integration then did for us is bring those team members into the primary care clinic. That promoted better understanding of how to treat common mental health conditions. This has been a really important thing for both our physicians and for our patients. And today, it is now a very important part of our patient-centered medical home and our model of team-based care.
In order for this evolution to change primary care practices, we developed 5 key processes that helped the team reach a level of confidence and cooperation that eventually resulted in improved primary care for their patients. We did this by creating a culture of cooperation, engaging patients and matching their complexity to the right level of support, integrating our EMR to give care providers the ability to communicate and track outcomes, creating a system that was financially sustainable, and utilizing community resources to help continue care after patients leave our facilities.
I need my doctor to be confident and treat me as a normal patient, linking up my mental and physical health.
I need my doctor to understand the complexity of my conditions, explain things to me, and ask my opinion. I need them to connect me up to the people they know and trust that can work together with them and me.
I want to be able to communicate with my team and share the information we all need to help our patients achieve their goals, especially when there's someone who is struggling and needs extra help from us.
I need to know where our gaps are and where folks are falling through the cracks so we can improve our process. I need to be sure all my team members have the tools and resources they need to do their job well. If we're all on the same page, our results will be better.
Part of my job is to link patients and families to community resources that can help them receive more care or stay well with the care we provide. Making sure that patients and families have the support they need to be well is all of our job.
Intermountain has studied the impact of standardized mental health integration on team-based care for over the last 15 years and discovered a significant improvement in clinical outcomes and a reduction in patient utilization of acute care, as well as overall cost savings to the system. This aligns with Intermountain's goals of keeping patients healthy, better able to manage population health and chronic conditions, and to keep costs lower for our patients and generations to come. Mental Health Integration's evidence-based care process model in our Intermountain Medical Group primary care clinics has resulted in 11% lower hospital readmissions, 23% lower emergency department visits, and a significant cost savings for our system. Intermountain invested $22.19 per patient per year to achieve these team-based care outcomes and benefited from an overall savings of $115 per patient per year. Furthermore, the value of having multiple team touches with each patient and their family makes patients feel more cared for in a coordinated way rather than a fragmented system. And the staff feel more supported and connected rather than isolated and dealing with this burden on their own. This in turn has improved patient and staff satisfaction scores significantly. These outcomes and benefits, though, have been achieved over time by significant effort by all the teams at Intermountain Healthcare.
Now we have the means to care for the needs of each patient.
I can follow up with a patient with diabetes or depression or both.
I can refer patients with chronic conditions who may have more complex mental health needs to my colleagues right here in my practice.
They provide timely consults and interventions and keep track of care plans and treatment progress.
Based on the complexity and severity of a patient, I can coordinate care with mental health professionals on my team according to their disciplines and roles. Whether patients need screening, coordination, support, education, or more involved psychiatric care.
I can better identify a patient's issues and treat the whole person, physically, mentally, and emotionally, and overall provide better care to help people live the healthiest lives possible.
Those are our real staff, so it was nice to have them here. Travis, have you ever seen that one? Okay. Great. So, thank you all for listening for 2 hours. That was hard to do.